Welcome to the deep dive. Today, we're going to unpack a really important study in vascular surgery. It's one of those papers that, well, it really shifted how doctors think about treating a condition called chronic critical limb ischemia.
That's right. We're looking at a study by Chung and colleagues published back in January 2015 in the Journal of Vascular Surgery, a real landmark paper. And our mission today is to explore why it made such waves.
Okay, so let's set the stage. Chronic critical limb ischemia, CLI. What are we talking about here based on how the study defined it?
Sure. So CLI in this context meant patients had ischemic rest pain or ulcers or even gangrene, usually in the foot or leg, that had been going on for more than 2 weeks.
Right, so persistent serious problems.
Exactly. And crucially, they had to have objective proof, tests showing really poor blood flow.
Okay, and who wasn't included? That's often just as important.
Good point. They did allow patients who'd had prior partial foot amputations, which is interesting, but they excluded people whose circulation problems weren't from atherosclerosis, hardening of the arteries. Also excluded were those who only had pain when walking, that's claudication, and anyone who'd already had a major amputation, like a below knee or above knee, on that limb.
Got it. So a specific group with advanced artery disease.
Uh-huh.
And the core question this paper tackled.
The big one was, does putting together a dedicated team, vascular surgery, podiatric surgery, plastic surgery, all working together from the get-go, does that improve outcomes compared to the, let's say, more traditional standard wound care?
And the specific outcome they were really focused on.
Amputation-free survival. So basically, how long patients lived without needing a major amputation.
Okay, makes sense. So how did they go about answering this? What was the study setup?
It was a retrospective study, meaning they looked back at existing patient records, single center, involving 146 patients.
One center. And how long did they follow these patients?
The median follow-up was pretty decent, 539 days. So well over a year, giving a good window into the longer-term effects.
All right, now let's nail down these two approaches they compared. What did multidisciplinary care, or MDC, actually look like in practice?
Okay, so MDC was defined as really collaborative care. Right from the initial presentation, the patient's management was directed jointly by vascular surgery, podiatric surgery, and plastic surgery. They were all in the loop, working together.
Like a dedicated limb salvage team, basically.
Pretty much, yeah, a coordinated unit.
And how did that compare to standard wound care, or SWC?
SWC was, well, less structured. Typically, the general surgery service might see the patient first. But after that, it could be a mix of different people involved. Maybe the general surgeon continued, maybe wound care nurses, primary care docs, physician assistants, sometimes even just the patient and family managing things. It wasn't that same consistent specialist team approach.
Right, I can definitely see how that could be quite different. Okay, the moment of truth. What did they find? What were the results comparing MDC versus SWC?
The headline finding, the main result, was about that amputation-free survival. And it was pretty striking.
How striking.
Significantly better in the multidisciplinary group. The average AFS time was about 593 days for MDC patients, compared to just 281 days for the standard care group.
Wow, that's more than double the time living without a major amputation or death.
Exactly. A really substantial difference. It suggested that this team approach potentially bought patients almost an extra year of amputation-free life on average.
Oh.
That's huge.
Absolutely huge. Okay, what about wound healing? Did the team approach speed that up too?
Well, the numbers did lean towards faster healing in the MDC group. About 445 days on average versus 625 days for standard care.
So faster healing with the team.
It looked like it, but interestingly, that difference wasn't statistically significant. The p-value was 0.74.
Meaning they couldn't be totally certain that difference wasn't just, random chance.
Precisely. So while it trended in the right direction, the really solid, statistically proven benefit was the amputation-free survival. That was the big takeaway.
Okay, so the team kept people alive and with their limbs longer, even if the wound healing speed difference wasn't statistically proven in this particular study. Did they dig deeper to see what factors really predicted bad outcomes, like amputation or death?
They did. They used multivariate modeling, which tries to isolate the impact of specific factors while accounting for others.
And what popped out as being independently linked to a higher risk of major amputation or death?
3 main things stood out. First, simply being in the standard wound care group, the hazard ratio was 2.664.
Whoa, hold on. Hazard ratio, remind us what that means.
Yeah, so think of it like this. A hazard ratio above 1 means an increased risk. So 2.664 means patients in the standard care group were over 2.5 times more likely to have a major amputation or die during the follow-up period compared to the MDC group, even after adjusting for other factors.
Yeah, okay, that's a big risk increase associated with standard care. What else?
Second, being a patient who didn't get revascularized. So no procedure like bypass or angioplasty to restore blood flow. Their hazard ratio was even higher, 3.76.
So not getting blood flow restored was a major risk factor. Makes sense.
Definitely. And the third factor was baseline non-ambulatory status. Patients who couldn't walk at the start of the study had a hazard ratio of 1.89, so almost twice the risk.
So the takeaway seems to be not getting team care, not getting blood flow restored if possible, and already being unable to walk. Those are all really bad signs.
That's what the data strongly suggests, yes. But, like any study, this one had its limitations. The authors were upfront about them.
Right. Transparency is key. What were some of the limitations they mentioned?
Well, as we said, it was a single center, and the patient population was from an inner city area, relatively small sample size, only 146 patients. So you always wonder, would these results hold up elsewhere?
Yeah, generalizability is always a question with single-center studies.
Exactly. And because of the setup, they couldn't really do a full propensity score analysis to perfectly balance the groups for potential biases. They also noted limitations in the data itself. Because it was retrospective, looking back at records, they didn't have detailed, standardized info on everything. For instance, diabetes management. How well controlled was each patient's blood sugar? That's a huge factor in CLI.
Yeah, you'd think that would matter a lot for healing and outcomes.
It almost certainly does, but they didn't have granular data on that. Also, some other clinical details, lab results, things like that might have been missing if they weren't routinely documented back then. And it's observational, not a randomized trial.
And they didn't look at costs, right?
Correct. No cost analysis was done, which is obviously a practical consideration for implementing these teams. Plus, they couldn't really pinpoint the ideal makeup of an MDC team from this study. Is it these three specialties? Do you need others?
Okay, so important limitations to keep in mind. But despite those, this study seems to have had a major impact. What was the context back then? Was multidisciplinary care already a big thing for CLI?
It was emerging. Some centers, especially for diabetic foot issues, were adopting team approaches. And organizations like the American Podiatric Medical Association and the Society for Vascular Surgery were starting to recommend it.
But was there solid proof it worked specifically for CLI?
Not really, not strong evidence. It was more sort of theoretically a good idea. This study provided some of the first really compelling data showing, yes, this coordinated approach significantly benefits these specific high-risk CLI patients. It moved it from concept to evidence-based practice.
And you mentioned it influenced guidelines.
Absolutely. It got cited in major clinical practice guidelines, like the ones from the American Heart Association and American College of Cardiology on managing peripheral artery disease. That's a big deal. It helped shape how doctors nationwide were advised to treat this.
What would you say was the single biggest aha moment or impact from this paper?
I think it was the sheer magnitude of the benefit, showing that MDC could potentially cut the major amputation rate roughly in half compared to the previous standard. That's profound.
Yeah, having amputations is a massive impact.
It really is. And it gave surgeons much stronger footing for conversations with patients about treatment options and expected outcomes. Plus, it provided ammunition to justify setting up these specialized teams to hospital administrators. You could point to this data and say, look, this saves limbs and improves survival.
That durability aspect, the amputation-free survival, seems key there.
Definitely. And another really interesting nuance the authors pointed out was that the improvement in AFS seemed to stem not just from better revascularization techniques, but significantly from better outcomes after partial foot amputations in the MDC group.
Ah, so the comprehensive care, the podiatry, the plastic surgery, the wraparound care really helped salvage limbs even when a smaller amputation was needed.
That's what it suggests. It highlights that revascularization is critical, but it's not the whole story. The expert wound management, the foot care, managing infection, optimizing healing, that whole package provided by the team seems crucial for preventing progression to major amputation.
Fascinating. Okay, so where did the authors suggest research should go next? What questions remained unanswered?
They laid out several key areas. One big one is nailing down the optimal team composition. Who absolutely needs to be on this team? Vascular, podiatry, plastics. What about infectious disease, endocrinology for diabetes, rehab specialists? social work.
Right. What's the essential core and what's the added benefit of others?
Exactly. And understanding the marginal benefit, how much does each specialty really add to the outcome? Then there's the cost question we mentioned earlier. We need solid cost-effectiveness analyses.
Makes sense. Anything else?
They also talked about risk stratification. Can we better identify upfront which patients will benefit most from this intensive team approach? Maybe some lower-risk patients don't need the full court press.
Optimizing resource use.
Precisely. And finally, the big call was for larger, prospective, multi-center studies. We need to validate these findings in different settings with more patients and ideally collect more detailed data prospectively, especially on things like diabetes control.
Okay, so to kind of wrap this all up, the core message from this deep dive into the Chung study seems crystal clear.
Yeah, I think so.
Multidisciplinary care, that coordinated team approach involving vascular, podiatric, and plastic surgery, provides a really significant, measurable improvement in amputation-free survival for patients with chronic critical limb ischemia when you compare to standard, less coordinated care.
Absolutely. And remember those key predictors of worse outcomes. Standard care itself, not getting revascularized when appropriate and not being able to walk at the start. It really hammers home the value of the team and fixing the blood flow.
It really does. You know, this study feels like a powerful example of a broad shift in medicine, doesn't it? Moving towards more collaborative, patient-centered models, especially for complex, multifaceted conditions like CLI.
It definitely points in that direction.
It leaves you wondering, where else could this kind of dedicated, multi-expert teamwork make a similar difference? What other complex health problems could benefit from breaking down silos and bringing diverse expertise together right from the start to focus on the whole patient? It's definitely something worth thinking about.